Hi everybody, this is Joe Betcher. Today we're going to talk a little bit about performing an ultrasound-guided femoral nerve block. This is a shortened version of the talk that I gave to the residency recently. Whenever I find a patient with a femoral neck fracture, such as this, I always first discuss this patient with orthopedic surgery. I let them know that I'd like to perform the femoral nerve block in the emergency department and make sure they're okay with it. After I discuss it with the patient, I'll have them sign the consent form, and then I'll go get my supplies. Most of the supplies you'll need are in the block box, which is at both the Hackley and Mercy campuses. You'll notice in the box that there's these special needles that have tubing attached to the end of it that can be hooked up to any syringe to push your anesthesia. There's nothing wrong with using any old needle if you're not comfortable with these, such as a spinal needle as well. Our anesthetic of choice is ropivacaine, which is similar to bupivacaine, but is less cardiotoxic in case you accidentally hit the femoral artery or vein. 20 cc's of ropivacaine is my typical go-to with a femoral nerve block. You'll want to have your ultrasound machine prepared in a full sterile setup, very similar to placing a central line. I always place the machine across from me so that when I'm doing the procedure, I don't have to try and turn my head and neck and look behind me. Rather, I can just look up at the machine and then down at the patient. People are typically a little bit more comfortable with their short axis view, which is seen in this picture. This is helpful for finding your structures, but makes it a little bit trickier to visualize the tip of the needle. For femoral nerve blocks, I prefer the long axis approach, as I can see the entire needle and the tip of the needle and know where I'm at the entire time when I'm doing the procedure. One of the more challenging things about this procedure is that the femoral nerve can be somewhat vague on ultrasound. Just remember, from medial to lateral, it goes vein, artery, nerve, and if your needle is going right up next to the femoral artery, or the patient's having sharp shooting pains, you're probably too close to the nerve and you can back off. You'll notice the femoral nerve lights up in bright yellow on this image. In this video, the femoral vein lies all the way to the far right side of the screen, with the femoral artery next to that, and the femoral nerve abutted up to the femoral artery, which is tough to see. There's a bright white line that's just above this neurovascular bundle called the fascia iliaca. This is important to know because if you don't get your needle deep to this fascia iliaca, you're not going to get good anesthesia. Now we see the needle entering the skin from the left side of the screen and just starting to enter through the fascia iliaca. We finally see that the needle is deep to the fascia iliaca and you're ready to start depositing your anesthetic. Even in this video, the needle is probably a little bit closer to the femoral nerve and artery than it really needs to be. Let's look at another example. This time we see the needle entering from the other side of the screen. You should be able to watch the tip of your needle the entire time you perform this procedure. When you're in the right place, you can deposit a small amount, 1 to 2 cc's of your anesthesia, and make sure you're in the right plane. You can see the spread of the ropivacaine in this video, and it looks as though it's above the fascia iliaca, and that lets you know you need to penetrate deeper to get better results with your block. We now see the needle deep to the fascia iliaca and all the anesthesia being deposited. You take your needle out and you're all done. This is just a brief summary. I'm always happy to talk more and answer other questions. Thanks everybody.